Good morning.
Good morning once again. How are you?
Fine, thanks. Do you hear me now?
We hear you just fine, so go ahead.
Just fine. Perfect. And sorry for the delay and the technical problem. Now we resume the case, live case, and Giampiero will summarize the data of the patient.
Okay, it's a 5 years old child, 19 kilograms, with a late diagnosis of absent left pulmonary artery and ventricular septal defect. That at 3 months of life underwent to catheterization, in which we showed a patent ductus arteriosus connected to the left pulmonary artery. So we decided to perform a recanalization of the PDA and a stenting of the PDA in order to retrieve the left pulmonary artery. At 9 months, was submitted to surgical repair with the closure of the ventricular septal defect and the connection of the left pulmonary artery to the main pulmonary artery with a residual left pulmonary artery stenosis. At 3 years of life, we decided to perform an angioplasty of the left pulmonary artery, and now we are here to stent the left pulmonary artery.
Now I will present the angios we performed just a few minutes ago, just to see the left pulmonary artery stenosis, the moderate pulmonary valve regurgitation, and the discrepancy of the sites between the pulmonary arteries. The right pulmonary artery measures about 10-11 millimeter. The left pulmonary artery measures about 2.8 millimeter in the stenotic segment and 8-9 millimeter distal to the stenosis at the site of the hilum. It was very challenging to cross the stenosis due to the orientation from the main pulmonary artery. So we decided to implant a pre-mounted stent just to avoid any dislodgement of the stent during the deployment and the positioning. We had chosen the Cook formula stent that has the peculiarity to be able to enlarge to the double of the sites at which we implant the stent. So we decided to put a 9 millimeter of the diameter stent, length 20 millimeter, just to cover the origin of the left pulmonary artery up to the hilum of the same pulmonary artery. So we crossed the stenosis using a right coronary artery catheter and a Terumo guide wire. Then we put a extra stiff Amplatzer cordis guide wire, over which we passed the 7 French long sheet Mullins well over the stenosis. Over this ensemble, guide wire and long sheet, we passed the stent, the pre-mounted stent, and put it inside the left pulmonary artery. Now we have to decide where to deploy the stent. And to do this, we use a control angiographies just to put the stent in position. The position should be good now, and we will check by repeat angios. Spingi la guida.
Can you show us any selected picture to show us where the side
Yes,
images
yes.
are of this pulmonary?
Could you image the, yes, we will show the
Ma quello a
angios.
fianco, sì.
Perfect. This is the frozen frame angio of the vessel with the diameter of the smallest part of the stenosis, and distal to the stenosis the branch is about 8-9 millimeter. So
Do you have any, I was asking if you have any angios selective in there to see where the branches and what branches you might cover with the stent.
yes,
Now we will now we will show
check
now.
just to see, in order to avoid the branching of the left pulmonary artery. Let's check now. So,
What sheet do you have here?
we use the 7 French Malins sheet, 75 centimeters long. The pre-mounted stent is about 10 millimeter, 9 millimeter of diameter and 10 millimeter of length. The stenotic part of the vessel is about 18 19 millimeter.
Which are,
Okay, now we check
which
it.
are the advantages? Excuse me, where are the advantages for the stent instead of Valeo stent, for example?
Yes, it's the same thing. It's the same category of stent. We are starting to use this one instead of the Valeo stent, but it's the same category. Has the same advantages. I think we have to.
You said before this was a pre-mounted stent. Can you just tell me what size balloon that is on and what's the final diameter you can achieve with that stent?
We will put a 9 millimeter balloon just to see if the dilation is enough. Then we will increase, if it's necessary, up to the desired diameter. We use this kind of stent in order to put the smallest as possible long sheet, because it's very difficult to cross the tortuous stenosis with a larger long sheet. Now we will check another time. I think we have to redraw just a little. The last check. Let's control. It should be good. It may be just a little forward. What do you think about?
I'm not sure. I just, it looks to me, how long is that stent again?
This stent is long 20 millimeter, and the length of the stenosis is 17, 18.
Okay.
It should be just a little shortening of the stent. Penso che possiamo.
Do you think you're proximal enough there?
I think it's good. We will dilate the stent. Okay.
And what pressure are you dilating to?
Up to 12 atmospheres. This stenosis is not completely relieved. It may be we need, maybe we have to wait for a complete relief of the stenosis. Now we deflate. We'll check by angio, just to see the position and the spingi giù e tira giù. Okay. There is a waste inside that we wasn't able to erase. We will
Well,
see
I'm
the
sure
position.
because I come from a deprived country, but I'm I'm not used to a pre-mount stent that you can double its size after you put it in. So what's the maximum size you can make the stent that comes
The
pre-mounted?
maximum size.
Okay. The maximum size we can dilate this stent is 18, and I think it should be good for the baby. Now we have to try to redilate the central part. We'll try to use a 10 millimeter balloon to put inside the pre-mounted deployed stent, just to try to increase the diameter. We decided to put the stent just a little bit backward to protruding into the main pulmonary artery, but in order to align the left pulmonary artery to the main pulmonary artery, we try to flare the proximal part of the stent, just to reach a better orientation of the stent. Just a few minutes.
All right, you're going to further dilate that particular stent today?
No, we do not use to pre-dilate this stenosis. We use to dilate, unless it's native stenosis, we try to dilate with the cutting balloon. Otherwise, if it's post-surgical stenosis, we go straight to with the stent, pre-mounted or not pre-mounted stent. Let's try to put another balloon.
Are you trying to put in a cutting balloon there
No,
now?
no, no, no. We don't use a cutting balloon unless it's a native pulmonary artery stenosis.
All right.
Distal.
I just didn't understand what you said before. Okay. So what size balloon is this?
It's a 10 millimeter large, 20 millimeter long balloon. Cook. And try to redilate just a little backward in order to flare the proximal part of the stent. Okay, here. Let's try. Okay.
Which is the pressure for that balloon?
We
Up
reached
12 atmosphere. That is the
okay.
maximum we can reach.
We take away the balloon now and perform an angio. I think despite the small waste inside the stent, I will leave the stent as it is, because if it's necessary, we will put another high pressure balloon later, just to perform a two-step procedure dilation.
We have a question from the audience.
Good morning. That's an excellent result. It was predicted that there's going to be a stenosis. Would you have considered, with hindsight, to do a cutting balloon, dilatation, and then stenting?
Either in a native or in acquired stenosis.
On the native,
On the-
not
yes.
on the stent.
Okay, on the native is our policy to pre-dilate with the cutting balloon, and then with the high pressure balloon, and then with the stent if it's necessary. But after surgical,
Did you do that here or not?
no, we didn't.
No. But with hindsight, do you think it would have been a good idea?
I don't know. Don't know exactly.
So would you consider using a much higher pressure balloon here, or are you satisfied?
I think we are satisfied. because we have to try to redilate with a higher pressure balloon later on, and just to increase more and more the size of the stand.
Well, let me ask the audience while we're here. How many of you would have pre-dilated this with a cutting balloon first? Only a small number. How many people would use a higher pressure balloon here, like an Atlas or something, Conquest or something like that, to open it up right now? A few more hands. Carlos.
I have a question. What was the surgical technique? Because this might have to do with the underlying tissue here. Is this native ductal tissue, or did the surgeon use the patch? Sometimes you cannot dilate, even using a cutting balloon. So I think this is the question we have to ask. And this is a good enough result, I guess, for these patients. Good is enemy of the better here.
Enemy is good and better. So, the choices would have been to use the cutting balloon first. Do you have the surgical history? Do you know how this was connected?
Okay. Do you think it could be good to redilate using a high pressure balloon 10? It could be an option. We can try to resolve the waste inside the stand using a 10 millimeter high pressure balloon.
I think you have it's your choice here what to do. We have to leave you in about 2 minutes to go to Belgium, but I think this is a very good result. I'm encouraged to hear there are pre-mounted stents that can be doubled in size.
We can try to.
I've not seen that before.
Yeah, we can try to redilate using a 10 millimeter high pressure balloon, and if it's too late for the broadcasting, we will show you in the afternoon before the next case.
All right. All right, that sounds great.
If you can wait
Congratulations
just
on an
for a
excellent
few
result.
minutes, we are almost ready to perform.